All right, hello everyone. Welcome. My name is Lindsay Jacobson, and I'm a clinical research coordinator at the Recovery Research Institute and the project lead for our institute's partnership with the Opioid Response Network. So welcome to the first Recovery Science Series webinar of 2025. We're very excited to have you all here, and we have a great presentation coming up. This webinar series is sponsored by the Opioid Response Network, which is funded by SAMHSA. And the Opioid Response Network provides local experienced consultants in prevention, harm reduction, treatment, and recovery to communities and organizations to help across this opioid crisis and stimulant use. Each state and territory has a designated team that is led by a regional technology transfer specialist. And the approach of the ORN is to build on existing efforts, enhance, refine, and fill in gaps when needed while avoiding duplication and not recreating the wheel. And the overall mission of the RN is to provide training and technical assistance via local experts to enhance prevention, harm reduction, treatment, and recovery efforts across the country, addressing state and local specific needs. If you would like to ask any questions or submit a request for technical assistance, you can visit the ORN's website, which is www.opioidresponsenetwork.org, or you can send an email to orn@aap.org. And here we just have about a 2-minute video that explains a little more in depth about what the ORN is and what it does. So go ahead and play that now.
Agencies across the nation are mobilizing to address opioid and stimulant use and the opioid crisis. We can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration. Communities across the national.
And here we have a list of our past webinars or past events. And our next webinar will be sometime in mid-June 2025, and more information on that is to come soon. And before we move on to the presentation, we just have a few polling questions for you all to answer. And just to let you know before I start the poll that there are 5 questions, so please make sure you scroll down before you hit submit. We'll just give it another minute. There's about 50% that's answered. All right, I'll go ahead and end the poll now and share the results. All right, and now I'm going to pass it off to Dr. Emily Hennessy, who will now be introducing our speaker today.
Great. Thank you, Lindsay. So I'm delighted today to introduce Dr. Brandon Bergman. He is an assistant professor at Harvard Medical School and associate director of the Recovery Research Institute, the RRI, in the Center for Addiction Medicine at the Massachusetts General Hospital. After earning his PhD in clinical psychology at Nova Southeastern University, Dr. Bergman's postdoctoral fellowship combined recovery research on emerging adults with co-occurring disorders at the RRI with clinical training at the hospital's teen and young adult outpatient addiction treatment program. Dr. Bergman's work has been funded by the NIAAA and the Massachusetts Bureau of Substance Addiction Services and spans several areas of recovery-related clinical research. These areas include online recovery communities and other digital recovery support services, mutual help organizations, strategies to engage individuals taking opioid use disorder medications with community recovery supports, and developmental perspectives on recovery. Dr. Bergman also serves as executive editor of the RRI's Recovery Bulletin, a monthly newsletter that summarizes, synthesizes, translates, and disseminates the latest recovery research for the general public. So if you're not on that listserv, please sign up today. And clinically, Dr. Bergman is a licensed psychologist in Massachusetts and a certified adolescent community reinforcement approach therapist. We're delighted to hear you talk today, Brandon. Thank you.
Thanks for that introduction, Dr. Hennessy. Can everybody hear me okay? Great. All right. So I'm going to share my screen. This one. All right. Can everyone see that title slide? Perfect. Okay. So yes, thank you everybody for being here. It's an honor to be with you. And I will typically be helping host this webinar series along with Lindsay Jacobson, but today I'm the speaker. And so I really look forward to being part of this webinar series related to treatment and recovery for youth and young adults with substance use disorder. So with that, I'll get started. Please put, throughout the talk, I'll stop a couple of different times to answer questions that folks might have. Please put them in the chat, and then we'll also carve out quite a bit of time at the end for a longer Q&A discussion. Again, please just put your questions in the chat, and then Lindsay will help monitor that, and we can help answer your questions that way. Here are my disclosures. I don't have any direct financial stake in any of the organizations that fund my work. So we're going to be covering 4 aspects of emerging adulthood today. This is a bit of an agenda for us. As you can see, we're first going to operationalize the concept, then describe some differences between emerging adults and their younger and older counterparts, outline challenges they face, and outline the challenges that we as clinicians and recovery support providers face in helping emerging adults with substance use disorder. And then perhaps most importantly, or just as, if not more important, we'll be proposing some strategies based on what we know empirically about emerging adults that can help address some of these challenges. And then at the very end, when we open it up for Q&A/comments, I'll definitely look forward to hearing any other kinds of solutions that you all have come across that you find helpful in working with emerging adults. So what is emerging adulthood? It is an extended period, essentially, of adolescence where folks are still aiming towards stability in terms of work, romantic relationships, perhaps starting a family, and generally related to a set of developmental milestones. And so it's a stage of life course that falls between adolescence and what I will sometimes call established adulthood. it's around ages 18 to 29. It's less an age range and more a developmental stage. But if you think around the ages of 18 to 29, that will give you a sense of when these different developmental milestones are relevant for emerging adults. Sometimes we use the term young adulthood interchangeably here, but because I will try to be as precise as possible, because here we're really talking about from a developmental perspective. But you see here that there are typically 5 transitions or 5 characteristics associated with emerging adulthood, including identity explorations, from going from instability to stability in one's life in terms of vocation and family, like I mentioned, self-focus, right? Meaning thinking about one's own life, not necessarily being self-centered, feeling in between, right? In between adolescence and adulthood, as is consistent with the title of the talk. And at the same time, a lot of adventurousness, possibilities, optimism, some risk taking, right? Which is normative at that stage, right? So that's what we think about with emerging adulthood. So here's just a little example of a survey that Jeff Arnett, who coined the term emerging adulthood, when he conducted a survey on a group of emerging adults. And you can see the kinds of statements that emerging adults feel are consistent with their experience, right? Not only is their life fun and exciting and full of changes, and at the same time, you know, they feel lots of freedom, but it's also stressful, and there's uncertainty and anxiety and so on and so forth. So let's talk a little bit now about differences between emerging adults and their younger and older adult counterparts when it comes to substance use disorder, because that's why we're here. And all of these factors that we were talking about before, and I'll get into that in a little bit more detail, all these factors that are consistent with emerging adulthood also place them at higher risk for substance use disorder, right? So first things first, if you look at the green bars, that represents emerging adults 18 to 25. These are from the SAMHSA National Survey on Drug Use and Health. And we see rates that are as high or higher than younger counterparts, or I should say higher than younger counterparts and as high or higher than older counterparts. Same thing if we're looking simply at cocaine and heroin use, slightly higher levels of cocaine use, but lower levels of heroin use. Now, most importantly, if we're looking at all drug use, right, the NSDUH classifies marijuana use as illicit, quote unquote. So if you look at the bars on the left, again, that green bar represents 18 to 25-year-olds, you'll see substantially higher rates of drug use, including opioid, stimulant, cannabis use, other drugs, not including alcohol, but they do have the highest rates of harmful and hazardous alcohol as well. But we sort of in this series of webinars, we're focusing a little bit more on opioid and stimulant use disorder. So here I focused a bit more on that. But if you looked at risk behaviors related to alcohol, you would see the same pattern, where 18 to 25-year-olds have the highest levels of risky alcohol use, including binge drinking, heavy drinking, drinking and driving, for example. And now just one other thing, if we look longitudinally over time, what you see is these rising rates of daily cannabis use, for example, right? So people will often think about cannabis use as either or, did they or did they not use? And I think, yeah, sure, that's instructive in some ways. What's really instructive is more intense levels of cannabis use, in this case, defined daily as 20 out of the last 30 days. These data come from the Monitoring the Future study. There's a longitudinal panel, and you see these increasing rates of daily cannabis use. And so, and this just sort of shows worldwide risk factor. Alcohol and drug use are the 2 highest risk factors for disability-adjusted life years lost, meaning healthy life years lost due to different risk factors. Alcohol and drug use are the 2 highest risk behaviors in that regard for young adults internationally. And then, not surprisingly, if we look at substance use disorder, meaning that across different substances for each one, some of you may already know this, but just broadly speaking, if we think about using substances, that cause consequences and someone continues to use them, broadly speaking, we think of that as a substance use disorder. Again, they have to meet a certain number of criteria, but you see these elevated rates for 18 to 25-year-olds, right? And at the same time, we see lower rates of treatment attendance. So this was that poll question. So those of you that answered 17%, congratulations, you were right. I actually think it was not the highest percentage. So not everybody got that. Now in this case, I saw a lot of people put 10%, which is sort of the standard value that people think of in terms of what percentage of folks seek specialty treatment. This includes lots of different kinds of treatments, including telehealth and seeking treatment in a criminal justice setting. So it's a little bit higher than that 10%, which is specialty treatment. So the other thing we know is that despite the fact that young adults have highest rates of substance use disorder, the lowest rates of treatment engagement, getting into recovery earlier for young adults is associated with better functioning. So these data come from the National Recovery Study, which is a nationally representative sample of adults who resolved an alcohol or the drug problem. And so along with John Kelly, we looked at people that got into recovery as a young adult between the ages of 18 to 30 versus as an established adult, 31 and up, and found that if people got into recovery between 18 to 30, they had about 1.5 times greater likelihood of current employment when the survey was conducted. Again, it's adjusted for age, right? Because the older one gets, the more likely they are to be employed. And if one got into recovery as a young adult, again, adjusting for a whole host of other factors, their current quality of life was greater as well. And those effects were even larger if you looked at people within their first 5 years of recovery, right? So what this tells us is young adults or emerging adults, they have a set of risk factors that increase the likelihood of having a substance use or meeting criteria for substance use disorder, other kinds of risky substance use behaviors as well, and yet they have lower levels of treatment engagement than their younger, older adult counterparts, which is concerning because getting into recovery as an emerging adult is associated with all sorts of good outcomes. So with that, let's just pause real quick. Next, we're going to talk a little bit more about the challenges of working with emerging adults, but are there any questions? We can sort of go through 1 or 2 questions, Lindsay, if there are any in the chat. If not, we'll just move on. Okay. So now we're going to talk a little bit more about challenges that we might encounter in working with emerging adults. And again, when I say working with, I think of that broadly. Working with in clinical settings and community-based recovery support settings, or just any of us that care about the well-being of emerging or young adults in today's world. So in terms of thinking about emerging adults, and what places them at risk for some of these substance use risk behaviors we were talking about before, the best way to think about that is they've got a lot of characteristics consistent with adolescence, meaning the imbalance that we all have as we grow up between our frontal lobe, right, the part of our brain that tells us to stop, slow down, think first before you act or plan, right? That part of the brain is still developing during adolescence, but the part of the brain, the limbic system, that consistent with feeling reward, emotion-driven behavior. Again, that's all normative, but that is much better developed earlier on in adolescence. And that would make sense as you think about the way that adolescents navigate their environments. That dysymmetry, that imbalance, still present in emerging adulthood. Our brains are still developing, and that imbalance is still present, and it takes a little bit of time for our frontal lobe to develop. The other thing that's present in adolescence, that's no longer present in emerging adulthood, is the natural social contingencies, being closer to family, being at school, right, where there's lots of teachers and other kinds of supports around. You take that, and then an emerging adult then moves into environments where they're going to have lots more freedom, whether they're in college or not in college. Now, college environments are pretty unique in some ways in terms of the amount of alcohol and other drugs around, in terms of the normative nature of risk taking, for example. The other piece that makes this more complicated is because alcohol and drugs are more present in the environments around emerging adults, it's that much harder for them to find places that could be recovery supportive if they're working towards reducing or quitting alcohol and other drugs, right? And so it may come as no surprise then that emerging adults are harder to engage in treatment. So if you think about their environments, there's a whole lot that's reinforcing risk behavior and alcohol and other drug use, again, many of which is normative and can be fun and exciting for emerging adults. So I say what I'm saying here with no judgment. But what happens then is if they do go to treatment, so it's harder for them to engage in treatment. And then when they do, they tend to have worse outcomes than their younger and older adult counterparts because in part, right, of these factors that I mentioned, and they have sort of lower access to recovery supportive people and environments. The other piece that's really important to mention is separate from thinking about outcomes, they may benefit from services in different ways. So there are unique aspects to being an emerging adult. So these data come from Project Match, which is a large randomized controlled trial for alcohol use disorder. And this looked at the effects of, or what explains benefits of attending the 12-step group Alcoholics Anonymous. Without getting into all the detail, the most important piece here is that for adults 30 and up, they benefit from AA in several ways, but primarily both by dropping people from their social networks that support their drinking, but also increasing the number of people around them that support their recovery. Whereas for younger adults, because they have lower access to these recovery supportive environments, AA helps them drop drinking supportive people from their networks, but they're not benefiting from AA by adding recovery supportive people to their networks, right? Because they have less access to that. So this is one of the many challenges in working with emerging or young adults. And so this is just a little diagram here summarizing several aspects, and they're not necessarily boundaried from each other. They all impact each other in reciprocal ways. But I talked about this limited access to recovery support at the top. The other thing we know is that emerging adults have the highest levels of co-occurring psychiatric disorders, major depressive and other mood disorders, anxiety disorders. And so one of the things we know is that just in terms of mental health more broadly, yes, you have certain disorders that are most likely to emerge in childhood, right? Like ADHD, for example, but the vast majority of mental health challenges that we as human beings have, if they are going to surface, they are most likely to surface during the ages of 18 to 20, in the age range of 18 to 29. I mentioned this persisting imbalance between the frontal and the limbic systems. The other pieces I haven't mentioned, although it won't come as a surprise, in part because of their environments that we mentioned before, the unique environments, they tend to come into treatment and recovery support service settings with lower initial readiness to change. Now, that doesn't mean their readiness to change doesn't evolve over time, but when they first show up, they're going to be much more ambivalent about change than their older counterparts. And they're going to have far fewer of these social contingencies that we mentioned that can help, right, enhance readiness or enhance motivation, which we'll talk about in a second when it comes to addressing these challenges, right? So in emerging adults, they have lots of freedom and they're still quite dependent on their caregivers, many of them, right? So it's that age of in-between piece that we talked about before that can be really, really challenging in working with emerging adults. This is just a meme from a few years back, and it's like the idea here is it's right within their grasp. It's sort of, you know, when they're in treatment, recovery support service settings, or we'll talk about some of ways to address it. There are lots of services out there for young adults at the ready for them. But the realities of young adulthood, of emerging adulthood, again, there's no judgment, through no fault of their own. This is about the realities of being a human neurobiologically, psychologically, socially, and culturally, right? The realities of young adulthood can make it very hard for them to sort of choose what would be the quote unquote healthiest thing for them to do in the long run, because they're thinking about what they feel like they need in the short term, and lots of environmental challenges therein. So before we get to strategies to address these challenges, which we'll spend a little bit more time on, because that's in many ways why we're here. I'll just stop and see if there are any questions in the chat. Nope, no questions. Okay. So there are several strategies that folks who work with emerging adults have used successfully, many of which have been tested empirically or at a minimum are based on what we know from the scientific evidence. And like I had mentioned before, at the end, we'll leave some time for Q&A, because I'll definitely be interested in, of course, if you have questions, and also if you all have had any successful strategies you've used and would want to share those with the group, or want to discuss those, or get my take on those. So first, we'll talk about using a developmental framework, and you'll notice that word throughout the talk, development. And again, we're sort of mentioning emerging adulthood as a developmental stage of the life course, because that is how to think about working successfully with emerging adults, is being ever mindful about their developmental needs, the unique aspects of this developmental stage, and so on and so forth. So in this case, the developmental framework that is helpful, that I find helpful, is if anybody took a Psych 101 course, you might remember Erickson's different stages of development. And at each one of these stages is a milestone, a developmental milestone or developmental transition. And this goes across the entire life course. And what makes emerging adults challenging, but for me, really fun and exciting to work with, is that the milestones that they're working on, and this is especially true for emerging adults with substance use and other co-occurring mental health challenges, is that their developmental milestones and transitions straddle several of these processes associated, both in some ways with early adolescence, right, where they're trying to develop a sense of agency, of the degree to which they can have an impact on their environment, the degree to which they're developing a sense of skill and accomplishment, right? Also later adolescence, developing a sense of oneself, identity, values, and then established adulthood and thinking about relationships and how we're going to form connections, where typically, again, I'm going to overgeneralize a little bit here, as we progress through developmental stages, our social networks tend to become sort of tighter and narrower, but deeper in terms of the depth of connection. And you can think about your own lives. And so with emerging adults, we're helping them work through those sorts of transitions. And the other developmental framework that I like to think about is a recovery-related developmental framework. So thinking about recovery as a longitudinal, right, over time, dynamic, changing process, and where if you're helping an emerging adult, thinking about that as one single experience that they're having as part of a larger process. So sometimes in the recovery space, we might say planting a seed. That's not my favorite analogy, because that sort of suggests it's this linear thing. When you plant the seed, the tree grows. We can oversimplify with metaphor sometimes. For me, it's more about just thinking and remembering that this is a process, and it's our job to meet emerging adult needs in any one given moment, and they may or may not take us up on the ways that we're able and willing to help there. And so in that regard, the other piece is being human or patient-centered, right? old school treatment recovery support services, as many of you all know, focused a bit more on adherence. And if somebody wasn't willing or able to show up consistently, then that setting was not the best one for them, right? Now, in this case, it's you could try that with emerging adults. It's just very unlikely to be successful. Here, prioritizing engaging emerging adults as opposed to thinking about them as adhering or not adhering to what we're offering. And so what that means in one context, right? There are lots of different ways that materializes, or that manifests rather. And I'm going to get into some of that. But one is accommodating both harm reduction and abstinence-based goals. And so I put this photo up just to remind me that this is not an uncommon strategy for us. So you think about cars and learning how to drive. There's all sorts of things that we do to avoid accidents entirely, and to avoid bad outcomes entirely. And there are all sorts of things that we have in a car that are there to prevent bad outcomes if an accident happens, right? Seat belts, and now there's all these different safety features, which are, like the sort of the blind spot notifications in our side view mirrors and all these kinds of things, right? So there are lots of different contexts where we do both and, right? We can help young people work towards optimal approaches for them, right? And in some cases, I would say in many cases with adults, abstinence is likely to lead to the best, certainly the safest outcome. And if emerging adults are not willing to do that, and they're not going to engage in treatment without accommodating or tailoring treatment to their goals, then we're not going to be able to help them, right? So really being able to accommodate their needs and the unique nature of being an emerging adult. And in many ways, letting them in a patient-centered or human-centered way, letting them lead the way or drive the car, so to speak. The other piece, which will come as no surprise to anybody, these data are old. I couldn't find more recent data, but whatever we're seeing here is just likely to be magnified. The long and the short of this slide and the point of it is just how much more likely emerging adults are to communicate via text message than any other communication strategy. And this is back in 2011. What we know is that in addition to text messaging being the most common form of communication among emerging adults, back in 2011, that number is definitely higher now. Across the US, they were sending a median number of 100 texts a day, right? So what does that mean in terms of us as treatment and recovery support providers? The extent to which you can and are willing, communication via text is much more likely to get a response, right? If a patient or a client doesn't show up and we want to reach out to them, you could try calling them, but you're going to have much more likelihood of success if you text them. So in thinking about what we can do, right, there are these different ways of tailoring treatment and recovery support services to emerging adults like we discussed. There are also some additional things to add to an emerging adult's comprehensive treatment and recovery support plan. And I'm going to get into just a couple of those. And like I said before, we're definitely going to carve out time at the end so that you can share any of the things that have been successful for you. So one of the strategies that empirically has been shown to be extremely powerful and potent is contingency management. Now, somebody might ask, well, we don't do contingency management. We don't, and I'll get into what that is. Basically, it's providing rewards in response to desirable behaviors, like sort of, in this case, we might think about treatment attendance or reduced substance use, for example, right? And there are different kinds of contingency management approaches, but that's the gist of it. It tends to be a reward-based set of psychological or behavioral principles rather than a punishment-based set of principles. And the other thing that we know empirically is that when family members are involved in treatment, outcomes tend to improve on average, right? So this is just one example of a review that was done. So now you might be asking, well, how do parents and contingency management fit together? So one of the things that I was trained to do and have developed quite a bit of confidence as one of the main strategies in helping increase young adults' engagement in treatment while they're working through a lot of the normative motivational ups and downs, right, that come along with being an emerging adult, the ambivalence, is that parents and other caregivers, especially for younger emerging adults, but really when we're talking about substance use disorder, even in the upper 20s, there's quite a bit of dependence on parents and other caregivers. So when I think about contingency management, there are a few principles that are important to keep in mind. And this would be if you were working with parents and other caregivers, for example. So you might help parents target a few behaviors first, right? In thinking about what behaviors you want to target or you want to help parents target, the mnemonic that I like is measurable, achievable, and desirable, or the ABLES, right? There are different ways of thinking about this, but the outcome has to be measurable, meaning the parent knows whether that outcome was achieved or not. Achievable sort of goes without saying, but don't want to establish a target goal that's too lofty, right? And desirable, meaning desirable to the parent and also to the young adult, right? So if nobody wants the outcome, then we wouldn't create that as a target, right? Treatment engagement and substance use tend to be good starting points, but they absolutely do not have to be. There's a range of outcomes. And then thinking about rewards, right? So sometimes people will say, I tend to say consequence if it's negative, although consequence just means something that comes after, right? So for a reward to be its most powerful, it's best if it's swift, meaning it happens as close in time to the behavior we're trying to change. For young adults, we're talking like 72 hours within, give or take, because what we want is for them to associate the reward, right, with the behavior we're trying to change. Certain, which means if a parent establishes a plan with their young adult loved one, right, that reward happens no matter what, inexorably, right? And then meaningful. So meaningful could be meaningful in terms of the behavior we're trying to change, or it could also be meaningful to the young adult themselves, the emerging adult themselves, because ultimately, if you think about us, right, there's all sorts of things that we get as rewards that make a behavior more or less likely to continue, but it's got to have meaning for us and got to be consistent with our values. So these are just some rewards. The mnemonic here is remembering like the C's. And I underline CAR because that tends to be both meaningful to the emerging adult and meaningfully related to the behavior you're trying to change. So if we're trying to change substance use, there's a very clear connection between, for example, testing negative on a tox screen and having permission to use the family car, for example, over the course of a weekend, right? But that meaning it's got to be meaningful to the young adult. You put cash or cash equivalents there. That's motivating for lots of us. It doesn't have to be cash. It could be a gift card of some sort, or some parents that I've worked with will create a separate debit card and where the 72-hour bit where after the talk, if a talk screen is negative and there was a certain monetary reward, then the emerging adult has access to their balance and they can see it. And finally, well, actually, I take that back. this is the second to last bit. So we'll talk about social network interventions, and then I added a little bit about technology-based or digital recovery supports. So there are several treatments that have been shown to be successful specifically with emerging adults. And I know this says adolescent community reinforcement approach. It's also been shown to be helpful with emerging adults, although not quite as helpful as it has been with adolescents. And without getting into all the details of these different treatments and the components of these treatments, they all incorporate social network change into the approach that is explaining how or why they're helpful. And so with the community reinforcement approach, for example, it's the fundamental crux of how it's intended to work is by helping emerging adults create, find, develop, cultivate rewarding experiences in their community to compete with the rewards of substance use. So basically, fun things to do that don't involve substances, right? The same thing is true for 12-step facilitation. That's about helping folks engage with local meetings, right? So, or it can be online meetings too. It's one of the things I'm thinking about and working on as well. And meetings tend to work. They work in lots of different ways, but meeting attendance operates most strongly through social network mechanisms, like we were talking about a few slides ago. Same thing with a treatment called network support. And then the other thing is to think about, in a similar vein, young adult specific resources in your community, right? So young adult specific 12-step meetings. There's this whole host of newer second wave meetings that have come after the development of 12-step groups so we did, without getting into all the methods, did a study looking at some of these newer meeting types. And we do see an effect where the younger, and this was the same national recovery study we were talking about a little bit earlier, and the younger somebody is, the more likely they are to have been to one of these second or new wave meetings, right? So there's a Buddhist centric set of meeting fellowships, recovery, Dharma, refuge recovery that have proved that seem to be quite popular, for example, among emerging adults. And there are collegiate recovery programs. There are recovery community organizations specifically for emerging or young adults. Most of this depends on what is available in your community. And generally, we see I just want to really quickly touch on what we see empirically is the power of social contagion. This is true for folks of all ages, but on the left is one particular session from an integrated 12-step facilitation created and tested by John Kelly, as the director at the Recovery Research Institute. And one of the sessions brings in a current member of 12-step groups. And one of the things he's told me from observation is how impactful that is on young folks in terms of being able to shift their attitudes about being able to go to meetings, right? And we see that also if we're looking, these data come from a study specifically of young adults that were in treatment and followed for a year. And here we see that the more meetings somebody goes to with people their own age, the better their outcomes are, at least initially. That does shift over time. So the overall message there is it's really good initially. And over time, people do tend to need recovery role models that have a bit more experience. And then finally, just want to talk a little bit about technology, and then we'll wrap up and get to any questions or comments people have. I'm very interested. So there are lots of different ways that we use technology in substance use disorder treatment and recovery support. I'm very interested in the ways that technology can facilitate peer support or connect people with substance use disorder and recovery to other people, right? So how it helps facilitate peer support, like I mentioned. And there's just a host of research suggesting that the same social processes that operate in person might also operate online. But there is more that we're learning, right? And so if you look at the very bottom, one of the ways that I think about technology as offering something unique is that It's lower threshold. People can access it from anywhere. They don't have to take up as much time. People can remain anonymous. And so it's a way for somebody to dip their toe in the water, right? And get exposure to these recovery social norms that might potentially shift up their attitudes. And at the same time, there are some potential drawbacks to be thoughtful about, where it might be harder for them to get actively involved in a mutual help or recovery support organization if they're accessing things digitally, right? So when people talk about quote unquote the meeting before, the meeting after the meeting, that might be harder to do, right? If you're going online, although we might think about online meetings as a conduit to in-person meetings, that peer-to-peer connection might be a little more challenging. We do see some data that suggests that. Privacy issues, we got to be really mindful of that. And then we got to be mindful about the digital divide too, where we know that people with lower levels of education and lower socioeconomic status tend to have lower likelihood of having broadband internet at home, which is really important to be able to access online services. So just to sum up, and then we'll transition to any questions. It's just a summary of what we talked about. So what did we learn today? We learned emerging adults are disproportionately represented in substance use disorder treatment and recovery support service settings. That they do benefit from earlier intervention, but can pose unique challenges relative to their young and older adult counterparts. There are innovative developmentally sensitive strategies that can help address some of these challenges. And in particular, when we can attend to social network change and some of the social network realities emerging adults face, consistent with their digitally immersed day-to-day lives, that may be especially helpful in addressing these challenges. So with that, thank you for your time, and we can move on to any questions folks have. And I just put up just a few ideas to kind of jog people's brainstorm here. If there's any challenges you've experienced that you want to share working with emerging adults, any strategies you've used, and maybe even what you find rewarding in particular about working with emerging adults, or anything you think we may have missed. So I'll stop there and see if there are any questions, Lindsay.
Yeah, we do have one question.
Okay.
Someone asked, in my experience as a certified peer recovery specialist in a university hospital setting and as a member of 12-Step Recovery, I've seen the impact of collegiate recovery communities on emerging adults. How can we incentivize universities to support this?
Well, A, great question. B, while we do need to learn more about the impacts or the effects of collegiate recovery communities and how they're effective, I know that people are doing NIH-funded work to look at that, and there are more and more papers published. I think I may have even seen that person on this call, right? So we're definitely learning more and more every day about the role that collegiate recovery programs can play in improving outcomes for emerging adults, and if so, how. The question asked is more of a policy question, to how to incentivize universities. And just full disclosure, policy is not my forte. So I do not have a specific set of recommendations for that. And at the same time, I'm a scientist. And so my go-to in thinking about how can we incentivize policymakers to prioritize what seems to be, or what we've observed to be helpful, is by putting out more good, rigorous science. And so by testing questions around, are our collegiate recovery programs helpful? If so, how and in what ways? And most importantly, by doing cost effectiveness research. Again, there is some of that good stuff happening already in terms of looking at not only does participation in collegiate recovery programs and other recovery support services for emerging adults, does it promote better outcomes, but what are the costs, and is it cost effective at different levels? And so I'm not a policymaker. If there are policymakers on this call, please feel free to add your 2 cents in the chat, or add any questions you have in the chat. But I do know that cost savings is part of the calculus in making decisions for them. It's one of the more important variables they have in making those decisions. So for me, it's like, how do we incentivize it? Again, many ways. Advocacy makes a big difference for me. I'm a scientist. It's about doing really good, rigorous science that includes not only examining outcomes, but also costs. Any other questions?
Yeah, a couple. So someone asked for emerging adults from people of color communities. I'd like to underline the importance of connecting people to culturally, ethnically, and racially welcoming groups. Recovery communities, oops, sorry, things moved.
Okay.
Recovery communities are a microcosm of the world where racism and prejudice also exists, creating additional barriers. For example, Recovery Dharma has a meeting only for people of color. Are there studies looking at this?
Totally agree. Something I'm very interested in is the role that online meeting modalities can play here, because one of the challenges in population specific meetings is access, right? Which goes along with discrimination, racial biases, and so on and so forth. So while there are meetings, for example, that are age specific for young adults, there are also meetings for specific racial and ethnic groups, for women, for example, for LGBT folks. And so I'm really glad the person made this comment. Thank you again for the comment. I'm not familiar myself with any research specifically looking at, because the research question here is, would somebody, for example, that identifies as Black or Latino, just to use a particular example, would they be more likely to attend and engage with meetings that cater specifically, right, to their communities, like the person mentioned, like the Recovery Dharma meeting? Would they be more likely to attend, and would they benefit as much or more than they would from other meetings? That's still a lingering research question, but we do see that, and I mentioned that just very briefly in this talk related to young adults and young adult specific meetings. We do see that attendance increases and benefit, at least early on, also increases the more people that are there that are of similar age. And so I think it's a very reasonable hypothesis, because the nature of shared experience is such an important one in why and how mutual help and other recovery support groups are, how they exert their effects. So I think it's a reasonable hypothesis, though I'm not familiar with any research myself. But because those kinds of meetings aren't as easy to access, I'm very interested in thinking about online spaces, because those can provide access to the kinds of population-specific meetings that can really engender that shared experience. Other questions?
Someone asked, what are your feelings on peer support as help during recovery and the inquiry of trauma as a cause to the addiction in the first place?
What are your feelings on peer support as help during recovery? Well, so part one first, my feelings on peer support help during recovery is based on what we know empirically. And we know far more empirically about peer support that takes place within specific mutual help organizations, and in particular 12-step meetings. We're learning a little bit more about some of these second wave groups, like I mentioned before, Smart Recovery, some of you may be familiar with. And a colleague of mine, Sarah Zemore, looks at some of these new or second wave groups. And we do see that, at least for folks with alcohol use disorder, outcomes do tend to be similar when you control for abstinence goal. So the more likely somebody is to choose an abstinence goal, the more likely they are to be abstinent. And that's more, there's a higher proportion of people with abstinence goals in 12-step groups versus other kinds of groups. So in terms of peer support, there's a ton of data suggesting that peer support within mutual help organizations promotes better alcohol and drug outcomes. We're still learning about recovery coaching specifically, if that's what this question refers to. There was I would like to point people to it's a publicly available review that led by David Eddy here at the Recovery Research Institute that several of us worked on. So if you Google it, I forget what journal it was published in. I mean, it's 2025, but the journal doesn't even matter at this point. Just Google peer recovery support services, Eddy, who's the last name, and you'll see, and look for a recent publication, and you'll see what we do see is very promising. And we need more research to really get a sense of whether and how recovery coaching is promoting benefit. I'm going to hold off on the trauma question. It's very important, and it's a little bit outside the scope of the talk, and I'm noticing the time, so we really don't have much time to get into that. And that is really for like a whole other talk or set of talks. This is such an important question, and I don't want to fly through it and not be able to do it justice. One final question we can take here, Lindsay.
One final question is a challenge I face in working with emerging adults, as one myself, has been the belief that the information they found online is more reliable than the information professionals give them in treatment settings. An example of this has been patients with cannabis use. What approach have you taken to address this issue?
Yeah, don't argue with them. So just for the sake of time, and Lindsay's going to cut me off in a second. We haven't really found how to improve like information literacy. That's a problem across many different health behaviors, as we've all come to learn, unfortunately. And at the same time, I've learned that showing them the data doesn't work, right? So using a motivational perspective, a readiness perspective, and that patient human-centered perspective, that's the way to go. But I think I'll stop there.
Awesome. And do you mind going to the last slide, Brandon?
Oh, sure.
One more.
Yeah.
Awesome. So just wanted to thank you, everyone, and thank you, Dr. Bergman, for that wonderful talk. And before we go, we just ask that you please click on this link I'm going to be sending in the chat momentarily. Just to complete this brief survey and give your feedback on this talk when you get the chance to. And we do have our next webinar, which will be sometime in mid-June. Again, more information to come on that, so please stay tuned for that. And just thank you all for attending this presentation. We appreciate it.